Hey everyone, welcome to this clinical explainer on the integumentary system. I am so excited to guide you through this. We're going to take foundational anatomy and translate it directly into practical, step-by-step physical assessments and nursing care plans. We'll be using some beautifully clear, realistic medical illustrations with step-by-step labels to really lock in this knowledge for your clinical practice. Let's just jump right in.
Here's our clinical roadmap for today. We're hitting 5 key areas: anatomy and basic functions, step-by-step physical assessment, identifying common skin lesions, caring for aging skin, and finally, managing impaired skin integrity.
Section 1, Anatomy and Basic Functions. Let's start with a baseline review of the body's largest organ. It's really easy to take our skin for granted, right? But it remarkably makes up about 15% of our total body weight. This beautifully detailed, realistic medical illustration perfectly highlights the 3 primary layers of the integument. Up top, we have the epidermis, followed by the dermis right in the middle, and then the deeper subcutaneous tissue down below. You can actually see vital structures woven throughout all of this, like nerve endings, hair follicles, and the sebaceous and sweat glands. Taking a second to visualize these layers is an absolute game changer, because every single assessment and care plan we make targets these specific depths.
These layers, working together, are absolute workhorses. They act as our primary first line of defense, literally shielding our internal structures from bacteria and physical trauma. But they do so much more than just protect. The skin gives us sensory perception for pain and touch, it balances our fluids, it regulates our core body temperature by tweaking blood flow and sweating, and it even synthesizes essential vitamins, like vitamin D3, when we step out into the sun. It's just a masterpiece of homeostasis.
Moving into Section 2, Step-by-Step Physical Assessment.
Now that we've got the foundational structure down, how do we actually examine it? Well, a routine integumentary assessment is never random. It follows a highly specific, step-by-step sequence. Step 1. You start with a visual inspection of overall skin color. You're looking for pink tones, maybe a bluish cyanosis signaling decreased perfusion or extreme pallor. Step 2. You move to tactile palpation. Yes, actually touching the skin to check temperature, moisture, and turgor. Step 3 is evaluating the scalp and hair distribution. And Step 4, wrap it up by checking the nails for color, shape, and capillary refill. Sticking to this sequence ensures you never miss a vital clue.
Now, I really want to emphasize this point for all the nursing students tuning in. Visual inspection alone just doesn't cut it. Palpation is absolutely crucial. This is especially true when you're examining patients with darker skin tones, where temperature shifts or the presence of elevated lesions, things like keloids or edema, might be visually subtle. You literally have to use your hands to feel for those changes in texture and temperature to get the full clinical picture.
All right, Section 3, Identifying Common Skin Lesions.
A huge part of your assessment involves identifying abnormalities and, crucially, using the exact right medical terminology to chart them. We categorize lesions by their physical traits. So, a macule, that's flat and discolored, kind of like a freckle. But a papule is raised and solid, usually less than 1 centimeter. If it's fluid-filled, it's a vesicle. Think of a small blister. And if that fluid is purulent, well, then you've got a pustule. Getting this vocabulary locked in is absolutely essential for clear, professional communication with your team.
To really grasp this, these clean, clear cross-section diagrams beautifully illustrate how different lesions physically alter the skin below the surface. In one diagram, you have a solid mass pushing right up above the epidermis, totally changing the surface texture. In the other, you see a fluid-filled pocket disrupting the deeper dermal layers. Having this mental model helps you visualize exactly what kind of tissue damage you're feeling when you palpate.
So, what does this look like in the real world? Well, structural changes often look exactly like this classic psoriasis plaque. Notice how those individual papules have coalesced to form this elevated, really wide mass? It's got that rough, scaly surface right there on the forehead. It is a textbook example of an elevated, palpable, solid mass that you would confidently document as a plaque.
Let's transition to Section 4, Caring for Aging Skin.
As our patients get older, we absolutely have to adjust our baseline expectations because aging dramatically transforms the skin. It goes from a robust, resilient barrier to a much thinner, significantly drier organ. That extreme dryness, clinically called xerosis, happens because sebaceous gland function drops off in those deeper layers. The skin just can't protect against trauma or thermal changes like it used to. In fact, older adults face a much higher risk for hyperpyrexia, or elevated body temperature, simply because their ability to sweat is reduced. It makes their skin highly vulnerable to injury and infection.
Because aging skin is literally that fragile, we have to be super proactive.
Nurses and family caregivers must teach and practice preventative hygiene. What does that mean? It means limiting warm baths to maybe just 3 times a week. It means restricting drying soaps strictly to the essentials: axilla, groin, scalp, and soles. And of course, regular application of skin emollients is an absolute must to lock in whatever natural moisture barrier is left. These are simple steps, sure, but they can totally prevent a devastating cascade of skin issues.
And finally, Section 5, Managing Impaired Skin Integrity.
This is where we bring all our clinical knowledge together. When that vital first line of defense breaks down, we use the formal nursing diagnosis, impaired skin integrity. Now, here is a really important distinction. This specific diagnosis applies exclusively to damage at the epidermal and dermal levels. We're talking abrasions, skin tears, surgical incisions, or early-stage pressure injuries. If the damage goes deeper, down into muscle or bone, you're looking at a completely different diagnosis. But for the skin layers we focused on today, this is your go-to.
So why exactly does skin integrity fail? Basically, it happens when the tissue's natural resilience is overpowered by physical forces. There are 4 big ones you need to watch out for. First is pressure, which blocks blood flow and causes ischemic injury. Second is shear, which damages deep tissue when the skin stays put but the underlying tissues slide. Third is friction, which literally just strips away the epidermis. And fourth is prolonged moisture, which macerates the skin and skyrockets the risk of breakdown.
Once you've identified the issue, you have to chart it correctly. Structuring your care plans is super easy if you use this fill-in-the-blank formula. It's simply impaired skin integrity related to, insert your specific cause here, like prolonged pressure, as evidenced by, insert your objective findings, say a 3-centimeter shallow open ulcer. It completely takes the guesswork out of charting. Whether you're managing a minor skin tear or a really severe diabetic foot ulcer, this formula keeps your documentation consistent and totally professional. All right, to test your new clinical understanding as we wrap up this explainer, I want you to think about a newly admitted patient. Ask yourself, what specific combination of mobility, age, and environmental factors would instantly flag them as a high risk for skin breakdown? Think about things like prolonged bed rest, advanced age, or maybe incontinence causing constant moisture exposure. Identifying those risk factors early, that is hands down the absolute best way to protect your patients. Keep that front of mind next time you step onto the floor. Thanks so much for joining me on this deep dive into the integumentary system.